Welcome to Barnsley CCG Governing Body Meeting in Public. Welcome to members of the Barnsley public. This is a live recording of the Governing Body Meeting. So good morning and welcome. So first of all, housekeeping, Kay. I think that's all due to us individually, isn't it?
It is, yes.
Yeah. And do we have apologies?
I don't have any apologies, no.
Okay, and are we quorate?
We are.
Yep, good. So we move then on to item 4, declarations of interest relevant to the agenda for any new or updated interests. Do we have any?
No.
No. And therefore we move into item 5, patient story. Jane.
Thank you, Chair. So the governing body patient story today is a true account of a Barnsley resident called Michael. The story is told by his social prescriber who supported Michael prior and during the COVID pandemic. It focuses on a few things that have come out of our collective response during the pandemic. Michael's case is very complex, and I'll hand you over to his social prescriber who will share his story with you.
Hi, I'm Claire. I'm one of the My Best Life team. I've been working with people who go to A&E either regularly or more times than we'd expect them to. And I'd like to talk to you today about Michael. I've been working with Michael since before we went into lockdown, before we even knew what COVID-19 was. And Michael had been up to A&E at the hospital 5 times in the month before I started working with him. He's got several long-term health conditions, epilepsy, COPD, asthma. He's had a heart attack and he wears a catheter, which he's had for quite some time. The main reasons he was going to A&E were due to seizures and problems with his catheter. When I spoke to Michael, he did tell me he has a district nurse who comes to the flat for his catheter, but that he forgets to stay in for his appointments and then goes to A&E to get it checked. He had previously been under the primary care service. He was referred by his GP. But after lots of onward referrals to mental health, social care, activities in the area, his case was closed due to non-engagement from him. He was also told that he didn't fit the criteria for mental health support. He did actually go to a local community group session, but ended up going to hospital in an ambulance because he said he felt faint. And he has had mental health social workers in the past, as well as support from a community matron, but again, because of what we call non-engagement, they closed his case. Michael's tenancy support worker told me that he struggles to socialise, especially in groups, and he himself told me he doesn't have any friends and that he's quite lonely. His neighbours were also regularly putting in complaints to the housing officer because they said that Michael spends all night banging in his flat and moving furniture. Michael was forgetting to keep his medical appointments, and I think there were some issues as well about whether he was taking his medication correctly too. So I spoke to Michael about seeing his GP for some help, some advice, and he did agree to go. I made the appointment as he wouldn't do that himself. And the GP spoke to him about how he feels, why he thinks he displays certain behaviours, and they referred him to SPA and prescribed him with some medication to help him sleep. Now, I've worked with Michael for a lot of hours and built up his trust to a point that he was actually able to open up to me about how he feels and why he destroys his property and his belongings. And it really has helped understand all the issues that were impacting on his health and how he'd been living. So with the arrival of COVID-19 and the lockdown, we've had to put a lot of things in place to support Michael. He has been struggling a lot during lockdown. Even though he should be isolating, he's still been going out and about, and it has caused him to start destroying his property again. I've spent some time explaining that to him, but he still wanted to go out. So I did find some easy read information online about COVID-19, about social distancing, staying indoors. So I printed that off, I gave it to him and asked him to read it. He didn't have a phone at the beginning of lockdown. He has had several mobile phones given to him by his tenancy support worker, but he's broken them. And he didn't have any internet access. And whenever he did get any post, he wouldn't read that. He would save it until I saw him. We'd go through it together. So during this time, his housing officer managed to get him a mobile phone so that we can contact him. And that's instead of me having to visit. And obviously he can use it in emergencies as well. He wasn't that bothered about the phone at first, but after a couple of test calls from me, he started to use it. I've registered him with the Vulnerable Person Support Line, so he receives regular food parcels, and actually didn't have any access to any money because the credit union he uses closed its building. So I supported him, contacting them. We set up an Engage card account, and that took at least 6 calls to sort. So that gives you an idea how these things aren't straightforward. And I can understand how someone would find that overwhelming. We were making really good progress before lockdown. Michael had been attending more of his health appointments. I'd arranged more assessments for him with a number of support agencies, mainly health and care related. Michael had told me he liked to garden when he was younger, so I was able to pass that on to the housing team. And before lockdown, they'd actually offered him a piece of land just next to his flat and some support there to do some gardening. So that was great. And a key to all of this was being able to work in a joined up way with someone who is vulnerable, they're known to the services, and overcoming that issue of referrals being closed and nothing being progressed. And we get a lot of cases like this referred to us, and we need to make sure that we do things differently, not just during COVID-19, but keep what we've learned to help more people live their best life, just like we did with Michael.
Thank you, Claire. Any immediate reflections or thoughts on Michael or the services or the support he's had? Can't see any hands up. Are you? Jane?
Thank you. Thanks, Chair. I think it was a real powerful story, and certainly when I read the case prior to obviously choosing the story, and just how, you know, how vulnerable some of these people are in Barnsley and, you know, obviously across the country, but how services such as social prescribing really pull the services together to support, you know, these complex, vulnerable people like Michael. So I found it quite, you know, quite a powerful story, and that this is not just an isolated case, this is happening across the borough. So a service that, you know, the Barnsley Clinical Commissioning Group have commissioned really makes a difference to the people of Barnsley.
Mark?
Yeah, I think it shows that how one-size-fits-all services don't necessarily suit everyone, and how flexible you sometimes have to be to reach someone.
Jeremy?
Thanks. Yeah, I think it just shows, doesn't it, that none of our services work in isolation, and we've seen through the C19 response just how important it is that we all do work together in an even closer way than we have done before. And it shows the opportunity we have with our PCN and with our neighbourhood teams to really build in social prescribing into that, and shows the value and power of that connectivity that they bring to the system. So thank you for the story, and I'm glad it's gone so well.
Okay, any other thoughts? Chris? Chris, you're muted.
When you actually look at the, as I describe it as a lay member, the non-pill solution to concerns, it when you actually listen to these stories, very often it's just one single item that can make such a difference to someone. And I remember someone who was into motorcycles, and that interest was reawakened. This particular individual, gardening, and how, I mean, we all know ourselves how therapeutic gardening can be. So it really is a question of working through My Best Life facilities and recognising what's not now, but what was in the past that interest people, that got people out of their own homes. And you know, the word gardening struck a chord with me for sure. And that comes back to my description of My Best Life is a non-pill solution to a particular problem. I sincerely hope this man continues with the gardening that's been found for him, because it can be a lifesaver for sure.
And that I think is interesting, Chris, because it's the continuation of improvement, isn't it? And the sustainability of that and the resilience of what's in place. And to some degree, commissioned services can help, but there is a big thing about community response, voluntary sector, and the community taking some ownership of this, because the sustainability of it is always based on its resilience. And that's always, I think, there when there's a lot of input or a crisis. But people that we don't necessarily recognise immediately as vulnerable, needing that level of support. And increasingly, I'm thinking that's got to come from community and voluntary sector.
Definitely.
As much as from commissioned services, which might help and coordinate it.
Yeah, our task going forward really is to make sure that some of those services that are in place are still in place when we come out of this, because unfortunately our conversations across South Yorkshire and Bassetlaw at lay member level are saying and suggesting that when the voluntary service goes to various organisations, one or two of them are no longer there. They've disappeared through lack of funding or whatever. So that's going to be a task that we need to address as soon as we get back to square one. And I'm looking forward really to re-establishing, hopefully via Zoom actually, the Barnsley Patient Story. Sorry, the Barnsley Patient Council, because it's something I really miss. I have kept in touch with a good few of them, including Barnsley governors as well, to keep people up to speed in relation to what I know, and which is more relevant from a non-clinical point of view, maybe. So, yeah, great story. Let's hope that young man keeps getting the support that he's got, and let's keep him gardening, eh?
Yeah, but I think if we wait till the end of COVID, whenever that comes, there will be very few voluntary sectors, organisations. So it's a thing we need to be thinking of now.
Most
Jamie.
definitely.
Yeah, thank you, Nick. It was picking up slightly on Chris's point, but coming at it from a different angle. So I think what comes out whenever we have any information shared with us about the social prescribing service, and we've had videos in our annual report and other things before, but it's the flexibility and the fact that we give, or the service give the social prescribing team that ability to sort of explore all of these different avenues. It's not got the structure that some of our other services have got, and that really comes out. And then just picking up the point about the gardening. So I don't know, but I was just sort of watching Claire as she told the story and started to smile more and more throughout telling the story. And a sort of big smile at the point of saying gardening. And we've heard that before around when people have helped people to get dogs and other things. So I think I just wanted to reflect, and it's a positive way, and say sort of thank you to the service around all of their sort of enthusiasm, the sort of commitment and enthusiasm to that service of the individuals that are providing the support always shines through and is brilliant, I think.
Yeah. Okay. I think at that point we'll move on. Thank you, Claire. And I'm sure. Oh, Dr. Addy Cunley.
Thanks, Chair. I just wanted to say, you know, it's very good that services are available that don't give up on individuals. So we get letters and communication. They have been discharged because of non-engagement, but here is a group of surveys that They say, well, this person is an individual. He has got the right to do the things that he wants to do, and they're there to assist him to live the best possible life that he can. So thank you, Claire, for not giving up on people like him.
Yeah, thank you. Okay, shall we? Thank you, Claire. Shall we move on now to item 6, please, Kirsty, patient and public involvement activity report.
Okay, so thank you, Chair. So the patient and public involvement report this month, clearly we're in, I think we call it unprecedented times. That has an impact on the changes to services that we've had to put in place. It impacts on what we're going to be doing in the future. And I wanted to highlight in this report particularly just some of the guidance that's come out from NHS England and NHS Improvement on our roles and responsibilities as a commissioning group. And then just highlight some of the work that's been happening in the background to try and hear from local people, local residents about how they've experienced services, how they've experienced life during the lockdown, because clearly it's it's a point in time that will have a significant impact on people going forward, and we need to be mindful of that. So a couple of points in the actual report. So the guidance that's come out from NHS England and Improvement is called the Good Practice for Working with People and Communities. And as you'll know, normally if we're doing service change or we're trying to develop services and hear from people about how they think they might work better for them, we'll be going out and physically talking to people. And clearly that's not possible at the moment. So the Good Practice Best Guidance says finding out people's views should not have an impact. COVID should not have an impact on that. So there's still a requirement for us to do that, and we have been doing that. And helpfully they've given some examples of different scenarios for us. I've included some of those just for our reference, because I think it's important. But I think it's certainly something we're going to be considering how we do that differently in the future. And the second point of the report is sort of brings us on to how we are going to do that differently. And we've got really, really good links and support from all the partners that have been working across Barnsley and across South Yorkshire and Bassetlaw on how we go out, talk to people, find out what their views are, and analyse that and bring that back in a I suppose in a speedy and effective way is what I'd say, because actually what we're used to is dealing with things on quite a sort of a project basis, and actually this is much bigger than that. This is going to be something that, as we heard probably in the patient story, there are things that impact on people's health that aren't health related. And actually, if we just go and talk to them about health services, we're probably missing a trick, I think. So we're working with the council, we're working with the hospital, with Swift, with Health Watch have been doing some work where they've been reporting so far on a monthly basis, a bit of a temperature check of what people have found worked for them so far, and what they might want to see in the future. So yeah, we've got a whole range of work that's going on that will sit. Just a bit of detail for you, that will sit with our intelligence unit, so all the excellent data reports and intelligence reports that have been coming out across Barnsley to help inform our work. The intelligence that we collect from members of the public will sit with that as well, so I'm really positive about that, because I think that's good to see, and we're starting to see sort of themes emerge, I think, certainly from some of the work that services have been doing around people's appetite for more digital appointments. With some communities that's gone really well. Excuse me. With some others it hasn't gone so well. They value the face-to-face, and I think as we probably pick up the items further on the agenda, I think we need to be clear that we need to hear the voice of local residents and local patients in making those decisions of how services work in the future for us. So I think they're the main points that I wanted to bring. And in terms of governing body, the ask is to note the guidance that's been given by NHS England and NHS Improvement, and note the work and support the work really that's taking place across not only the CCG but across the partners, to be able to deliver some of those things, I think, back into our day-to-day jobs. Thank you, Chair.
Well done, Kirsty. Any questions for Kirsty? Jeremy?
Not a question, just to reiterate the importance, really. We've been through a process of unprecedented change over the last few months in terms of the way we've delivered services in response to coronavirus. We're now moving into recovery and stabilisation, and we've got the opportunity to lock in beneficial changes. But in doing that, we need to make sure we are really engaging with patients and the public and the citizens more generally to make sure that what we think are beneficial changes from a health perspective generally meet the needs of the population. So it's just a really fundamentally important piece of work that Kirsty and her colleagues are engaged in.
Okay. Jane, your hand's up. Jane? No?
No, it's not up. Sorry, Nick.
Okay. Okay. Any other points? Any questions? Chris?
Yeah, I mean, my plea would be to my clinical colleagues, all the GPs in Barnsley, that they just rethink and revisit their own individual practice patient groups, call them what you will. Some people call them PPE, some people call them PRGs, but it can be a neglected part of our engagement. And as I say, if I have one plea, one ask of my GP colleagues is to just ask the questions yourself within your own GP practices as to what's happening, how robust are these meetings, are you getting any benefits out of it? Because I know that the people who take the time and the trouble to come along to Barnsley Patient Council have some real positive input back into the practices. So it's there. We've all got these groups within our practices. Let's use them. Let's use the strap line, which I was involved with right at the start of it, was your voice, and I do impress that on people who come along and say, look, there's our strap line. It's your voice that can help you. You can help your own relatives, and you can help your own practice to take things forward. So that's my ask and plea from my GP colleagues.
Thanks, Chris. Leslie?
Thank you, Chair. I was going to ask Kirsty about progress in recruiting the 3,000 voices, but having listened to Chrissy's question, I suppose it's slightly different, which would be anything that we in Barnsley need to do to support, be it through our patient group, patient reference groups, etc., to support in the recruitment of the 3,000 voices and making sure that we've got good representation, which is demographically representative from Barnsley.
Yeah, I think so that work hasn't started yet. It started, the planning work started, and I think we're looking to launch that sort of mid this month. One of the things that I'm keen to see is, I suppose it's just reflecting back on the patient story. So Michael, who's clearly somebody that uses our services a lot, uses lots of services a lot, and therefore something that is perhaps not, you know, there's lots of people, but they always seem quite a small group, but actually they take up a lot of their time and a lot of time to be able to offer them the right support. It's how do we get those sorts of people? Because actually by doing things demographically, yeah, that's great, and we'll get a good cross section. But you know, Michael wasn't on, didn't have access to the internet, didn't didn't buy the newspaper, didn't read his letters when he got them, and that's not unusual. That, you know, we probably think that's unusual for how we, you know, live our lives, but actually that isn't unusual. So I think one of the big things that we've picked up, certainly in Barnsley over the past couple of months, is work that we will be strengthening with the local authority. So we already provide funding to the local authority to be able to reach out into communities and talk to people, and the work of the emergency contact centre and the work that they've been doing with people who've been shielding has been fantastic, and I think for me that's where we need to be investing some of our support and time and some of that work with partners to be able to do that, because I think what we'll be in danger of is recruiting 3,000 people who are very keen to sign up and are the people that, you know, always sign up to things, and that's great. But actually, I think there's something about how do we make sure that some of those other groups are included in there, and if we can't, then we do it some other way, because I think that doing stuff digitally online will be great and will be helpful for us, but we can't lose sight of those other groups of people and communities that we want to speak to.
Thank you, Kirsty.
Okay. If there's nothing else on item 6, then we'll move to 7, questions from the public and responses. I understand, Kirsty, we haven't received any on this occasion.
We haven't, no. So because we're meeting virtually, normally we'd have people sat in the room with us if they wanted to come along and ask questions. This time we've given them the opportunity. So when we've posted the papers on our website, it's clear on there that you can submit a question. But we've had none this month, so yeah. Okay,
so perhaps the question we should take forward in this is John Fry's inverse care law. So as we reset and refresh, the most vulnerable are at the greatest risk of not seeing any of the benefits and being excluded. So that's a real question that I think if the public were here, they would ask us, how do we address care to the most vulnerable? And that's a big challenge. Has somebody admitted John?
Yes.
Right, okay. So, okay, then we'll move on to 8, which is minutes of the extraordinary governing body meeting of the 18th of June, which is here for approval. You've all had time to have a look through. Any comments or questions or issues with the minutes, or can we approve those? Okay. So we then move on to the, thank you, those are approved, and move on to item 9, matters arising report, where we look at the outstanding and any completed actions. Jamie.
Yeah, thanks, Chair. So apologies, you've not got the update in there, but the first few, I've got my name beside LinkedIn with Julie as well. This came out from the conversation that we had in March when I presented an update in terms of primary care. So we talked within that around the releasing time to programme, the releasing time for care programme and where it was at, and asked for a little bit more work to be done around how effective that would be. What I'd agreed with Julie is that would come back along with most of the other points in the next primary care update. So we do the work, bring it back in, but obviously we've just been thrown out a little bit on that. So we will make sure that comes back with more detail in the next report. Likewise, the second point, we talked about what's happening in Barnsley, but we asked that we also make the links across to what's happening at an ICS so that we can share that. So that will be included as well. In terms of Doctor Link, we looked into that further. I think what I would say is that the system is quite flexible. It's responded really well during COVID, so created new pathways and other things to make sure people were signposted to the right services if they had symptoms, for example. It can stream and identify alternatives to a GP appointment. What it doesn't do at the moment is offer the ability to book into other appointments in other providers. So that's something that we might want to consider and look how we can implement that in future if we were using this system or an alternative. And the other thing that it doesn't allow us to do, which is quite important, is understand what the patient then chooses to do. So if the triage through Dr. Link indicates that somebody should have a GP appointment and it allows them to book it, that's fine because we can see if they come. If it suggests that they could access a pharmacy to get their support or that they need to go to A&E, we can't see whether they actually do that. So there's no follow through in that sense. So there's maybe a little bit more that we need to do to understand how patients behave and react on the back of the triage. So that's an update on Dr. Link. But I think
just catch you there, Jamie. There's another bit about Dr. Link when we were looking at accident and emergency in clinical forum.
Yeah.
That if we blend it with our right care, right time approach and our community directory of services, it will enable A&E clinicians to also know what's available in the community. And that might just open up some of the congestion that we see in A&E if we can get a blending of those two. And it was in the context of NHS 111.
Yeah, to allow us to turn patients around and then get them directly back into the appropriate service. So we'll pick that up.
Yeah.
And then the fourth point, which is quite apt given that we've just had the patient story, was around the social prescribing service. And I think we referenced that there would be a review around effectiveness, engagement and all of that sort of stuff as we come to the end of what would be the current contractual arrangements, and as we start to look at what the options are around primary care networks, for example. So that will come back to governing body at the appropriate time.
Chris, you were flagging, go on.
Yeah, if in fact we are going to continue to try and encourage the general public to listen in, to watch these meetings, I think we've got to be very cognizant of the fact that we talk about SYB, ICS, Dr. Link, social prescribing, and whilst we know what we're talking about, I have to ask the question: would people understand some of this jargon that we keep on about? ICS trips off our tongue, SYB trips off our tongue. So I would ask at some point that as and when these things come out, from time to time, we might just actually tell people what ICS is and SYB is to keep people still interested in what we're saying, because you can get very switched off by jargon, can't you?
Yeah, that's a fair point, Chris.
I think it's come up before, Richard, and I think we said at one point we would have a bit of a, almost like a user-friendly glossary of terms or something like that.
Yeah, I think that's right, Nick. And I think that's something we can certainly pull together, isn't it? I can have a work with Kirsty on maybe pulling something together, and we can put it on the website with the agenda papers.
Yeah, that would probably be helpful to a lot of people. Okay. Anything else on matters arising? No? Okay, thank you. Thank you for that, Jamie and Chris. Can we move on then to item 10, Jamie, COVID-19 response update and the appendix with the Gold Command decisions in?
Yeah, that's fine. You can hear me, can't you? I'm not on mute. Yeah. So a fairly brief paper this time. Governing body members have been receiving updates throughout. So from March, we've been providing those to you. So this is an update on things that have happened really since the 28th of May. So less frantic, I think, over that period. And you'll be getting a separate report, which Jeremy will present, or a presentation after this, which is focused more around sort of stabilisation and recovery. So I think key points to note that we are still in a sort of level 4 situation. So national command and control arrangements remain in place. There has been some changes around the restrictions and other things in place, but in terms of the NHS, we are still in a level 4 situation. And therefore, the temporary changes that we made and agreed through governing body around decision making remain in place, including the delegations. Command and control structures then locally, and coordination structures. We continue to have our Barnsley-wide coordination arrangements in place. So through a sort of gold, looking at the strategic picture, a silver tactical group, and bronze operational groups leading on pieces of work around discharge to assess, care home support, A&E, community resilience, and a range of other things. What has probably happened since the last update is that there's been more work to try to create capacity within those groups to look forward and beyond COVID. So as we start to sort of move forward, what do we want to prioritise in terms of making sure that we are providing the right care and support for our patients? And within that, Nick, I think is an important point you made around our most vulnerable patients and how we build them in there. So that continues within the CCG. We continue to have our silver, what we call the silver group. Again, it's the sort of coordination group linked in with Barnsley Healthcare Federation to make sure that we've got a joined up approach to supporting the CCG to deliver its statutory functions during this time, but also to support primary care to make sure that they're able to respond to all of the guidance that's been coming out, the different ways of working, etc. So section 5.3 of the report then does pick up just a few of the key changes or developments that I thought it was worth picking out. So I'll not go through detail massively, but support to care homes. So a lot of work probably just started but continues to support care homes, including training on infection prevention control to all of our care homes, and beginning to develop the model of support, multidisciplinary teams providing support into care homes, every care home having a named clinician who provides support to them. And Jane, as our chief nurse, has led all of that work with partners, and I think done a fantastic job there. We've continued to support around shielded patients and the work there, so that practitioners are able to contact and do that. There's been a lot there through our medicines management team, so Chris Lawson and the team putting a lot of time and effort into supporting that process, along with other colleagues in the council and within the CCG. We've continued and extended the COVID-19 home visiting service to make sure that patients who are symptomatic are able to and housebound are able to receive primary care support. We've also, it's not in this report, but continued to provide the clinic for COVID patients to make sure again that they can be able to receive a primary care service. Intermediate care, so changes around intermediate care that are flagged there, and the ability to make sure that we've got services outside of hospital to link in with the discharge pathways. And there's been a lot of work to get in place the local arrangements that we've needed to make sure that our population, our staff and others can access testing as appropriate. And most recently that's included access to the antibody testing. So I think that's it in terms of the key changes. Appendix 1 lists out more in terms of the detail of those, and probably includes a few more things that we've decided. And then 5.4, which I think is really important and has been a priority for us throughout this process, but has sort of come up the agenda nationally and everywhere else more recently, and that's around supporting the workforce and making sure that we've been undertaking appropriate risk assessments for all staff, but particularly those staff who may be more at risk during this time. So we think we've had fairly robust processes in place, given that we've facilitated all of our staff to work from home since the end of March, which has enabled them to be in a safe environment rather than the office. We've been through a series of one-to-ones with all of our staff. At the time of writing, I think there were 104 out of 124. Richard might come in just if you've got an update, but I'm sure that is much closer to 124 now. I think that was just that some of the papers had not filtered through, and we're just on with the next step, which is those patients who identified that for any reason they felt that they were at increased risk during this time. We're doing follow-up risk assessment and identifying additional actions that we can put in place. And I think it's quite interesting, but one of the things that's come out of that work and that risk assessment is that for some people, we can improve their ability to work effectively and improve their health and safety by providing a safe and supportive workplace outside of their home. So recognising some people have not got access to space or facilities to work as we need or as they want to. So from next week, there will be a very small group of people who will be supported to work back in Elder House with some guidance and support and restrictions in place to make sure that they're able to remain safe. So I think that's probably all I wanted to say for today. I don't know, Richard, did we have an update in terms of the numbers? Or
I don't, Jamie. No, I'd sort of asked if I could have those, but I've just checked my emails and it hasn't come through yet. But I agree with you. I think the numbers have definitely ticked up from the ones that are in your report. So we can share those around when I've got the updated figures.
Yeah.
If I can just come in there, I think one thing that is important is that as we do more working from home, is that for very important patient or client sensitive and confidential discussions, for some people it will be difficult to get an appropriate space.
Yes.
And that's, as we've seen when we've done our meetings, we get little interruptions here and there. And I've got the builders here today. I don't know why they decided to come today, but they're here. And there are a few things, and I think for some people it'll be a real challenge. And we hear stories, people working in small attic rooms, bedrooms. So if we can facilitate a more sort of supportive and safe environment for them, I think that's a really good thing that you've done in discussing that with individuals. Yeah.
Yeah, and we did have some examples exactly like that, where we've supported people actually a little bit earlier. So we have had a really small number of people who've been able to access now because of those issues. I think the big thing has been to continue to have the regular conversations with all of our staff, because doing it once tells you the position then, doesn't it? And things change throughout. So we've been trying to make sure we do that throughout.
Okay, any questions or points anybody wants to make? Any questions for Jamie? No? Okay, thank you, Jamie. Thank you. On to item 11, COVID-19 stabilisation and recovery. Jeremy, please.
Thank you, Chair. Would it be helpful if I share the slides? I'll put them on screen because it is a presentation. And can also apologise in advance, because it appears that my neighbours have tree surgeons in. So if you hear the chainsaws, that's just one of the pitfalls and perils of working at home, I'm afraid.
Send them to the bottom of the garden first. Thank you, Jeremy.
Sharing now. Let me know if you can see it, please, because I lose sight of you at this point.
Yep, I can see it.
Thank you. So we've only got 10 minutes, and obviously conscious that we did spend a good couple of hours on this at a recent governing body development session. But I do think it's important that we do now share this at the public meeting as well, so we can be clear, both with ourselves and the public, about the future direction that we're taking in regard to recovery and stabilisation. I've moved on to slide 2. Has it moved on for you? So I'm on the agenda now. Thank you. It doesn't always. It's the confirmation it's working. So we're going to very quickly go through what we planned for, what we've seen, how we've responded to this point, a little bit about what we've learned, where we are now, and then obviously there is an ask, this the GB ask, and this is just confirmation of what we did agree at the governing body development session on the 25th of June. So if you remember back 3 or 4 months, it's been an extraordinarily hectic time for us all, and a time where many people have experienced a whole range of emotions, and of course a number of people have been very ill and sadly lost their lives as well. We in the NHS, working with our partners, have been doing our best to respond to that. And if you remember back at the start of this, we really thought that we were going to be seeing a peak. This is the blue line. that would completely overwhelm the NHS. So at that stage that the government brought in lockdown, social distancing and the self-isolation. And because of that, we were able to see that those measures did in fact work. We didn't see this peak, which would have overwhelmed the NHS. And instead, we've seen a level of activity which we have been able to manage in all our care settings to this point. Although I would note that all our services have been working at max capacity and staff have been going above and beyond throughout this entire period of time in order to deliver the standard of care that we wanted to do. So what we've seen, we have seen that Barnsley has had higher recorded rates of coronavirus C19, as I'm abbreviating it, than the national and regional average since the onset. We do think this is down to being a mix of proactive testing. We do have an older and more deprived population in terms of our social economics. We've got more underlying diseases, which can increase susceptibility to C19. And we do have a higher than usual density of care homes and natural disease variation. So there is a reducing trend in C19, which we've seen nationally. It's been slightly more resistant here in Barnsley since the initial peak tailed off, but it is going down now. Our 7-day rolling average indicates that it continues to reduce, and we haven't seen any increase in cases since the peak. There has been a stubborn baseline, which has largely been driven by clusters of cases in some warehouse and distribution facilities and outbreaks in care homes. And I think that we have responded as a system well to that, and we have been able to identify the source of those outbreaks and contain them. And of course, we now have our local outbreak engagement board as well, overseeing that process, led by the local authority. So I've seen those clusters starting to dissipate, and we are now seeing earlier signs of recovering a reduced trend in Barnsley, which is back more in line with the national trend. Clearly, as C19 continues and social distancing and lockdown is eased, we will have to continue to monitor that very, very carefully indeed, and that is the work of our intelligence unit that Kirsty referred to earlier, who have been producing for us on a regular basis, like a very good surveillance report which has come out on a regular basis, enabling us to see with some clarity what the situation is, not just in our hospital, but right across the health and care system in Barnsley. So how have we responded? We did a number of things differently. Some things we did as a health and care system, and some happened as a result of social distancing and self-isolation and the changes in the way people perceived the risk to them and their families in terms of how they access services. But we have seen a good flow of people in primary, community and secondary care services who put in place procedures early to allow us to, for instance, put in place discharge to assess our D2A model from the hospital in order to maintain appropriate capacity within the hospital, as they're also in the process of really ramping up their critical care capability as well. Seen a lot of moves towards digital or triage first. We were lucky in that we had the foresight to put a lot of that technology in place. So when Jamie was referring earlier to Dr. Link, that enabled primary care to respond by simply switching on systems and starting to engage with their patients in a different way, which I think put us in a very good place at the start of this process. We've learned as we've gone through this just how important all our services are in the way in which they work together. And I think we've seen a lot more integration of our services. We've seen people come out of their traditional care settings. So for instance, hospital occupational therapists and physio have come out of hospital and worked in the community alongside community teams. And we've really learnt that our care homes are a critical part of our health and care system in terms of the beds that they have and the residents in those beds and how we wrap services around them to make sure they are as protected as possible. Local authority have done some great work with their contact centre, which they set up inside a couple of weeks. And we've been working with them to produce a shielded patients list, not just based on the national NHS digital shielded patients list, but more widely, those who we determine have vulnerabilities within Barnsley and to be able to reach out proactively to support those patients and citizens over the last few weeks and months. And of course, throughout all of this, we are very conscious that we need to support our staff and communities within this. and support the emotional well-being of our staff, as we have been through a 3 or 4 month process which has been draining and tiring, but we still face an ongoing continuation of C19, and we're also trying to switch back on services which we had to suspend. So the picture is that it has been through a lot. We still have a lot to go through, and we have a winter period coming up as well, where we are yet unclear on which scenario is likely to play out there. Will we see a second peak? Will we see flu? Could we see them both together? We have to be able to plan for the worst case. How do we work together? Well, it's collaboration, collaborative leadership and partnership, rapid redeployment of staff, sharing resources to meet the most pressing challenges, so mutual aid across Barnsley between all our organisations around PPE in particular. We saw a lot of sharing. Organisations were running short, other organisations stepped in, and we were managing that process on a daily basis. And throughout the process, we did manage to just about maintain sufficient PPE supplies in our core services, particularly those who had immediate contact with patients suspected of having coronavirus. And importantly, we were flexible and agile in our response. So what are the key enablers? Well, we introduced our own Barnsley-wide response to this. So we have our Barnsley Health and Care strategic coordination groups at gold, silver and bronze levels. And we're working and able to make some rapid and responsive decisions on the stage a daily basis in order to meet the requirements that were coming our way. But a focus on outcomes, with a real focus on shared data and intelligence, and that's the intelligence unit that we've now pulled together. And it's absolutely fundamental to us now that in the future we do enhance our ability to share that information with each other on an ongoing basis. So what have we learnt? We learnt that partnership works. Only by working collectively together can we deliver at pace and scale to support our local people. We always knew that, but this is a real enabler to allow that to happen. In that a number of the systems and processes by which we normally take a more considered and careful approach to service change, we had to suspend those and just become extremely agile and responsive to needs and work together rapidly and responsibly to deliver against those needs. We think in future that the concept of a Barnsley place-based caseload, looking holistically across health and care, probably building on the vulnerability index that we've been developing to identify our vulnerable shielded population, will be important to us as we prioritise services and people in terms of how we get them back into the health and care system. Clinical and professional consensus as one. I think moving towards, we already had processes in place to move us towards integrated healthcare governance for Barnsley. I think that is now a future direction which is clear to us all as something that we need to deepen and strengthen. And the holistic prioritisation of health and wellbeing and equitable offer, we need to work through how we're going to maintain that over the next few weeks and months as well. And clear and consistent messaging and communication. We had to do a number of things in a very responsive, agile way, but now we need to make sure that we are thoroughly engaging with our patients and citizens to make sure what we do from this point onwards is reflective of their needs and concerns as well. So where are we now? We had some agreed principles for partnership working before C19. Those principles and the operational understanding of those principles has been strengthened and deepened, and the importance of system leadership and partnership working has been reinforced. We know that also we have to have shared leadership and governance to deliver financial balance across Barnsley as a system, and that's fundamentally important to us to ensure that we can continue to deliver the right services in the right place at the right time. And also, just in terms of quality and efficiency, we had a transformation plan in place pre-C19 to focus on these issues and to achieve financial balance. And I think our learning and reflection as we've been through the processes that those were the right priorities actually, and that we need to just now continue to press on with those with our partners over the next few weeks and months. So in terms of priorities, probably until March 21, we've summarised these into 5 key priorities. One is that we have to continue to manage C19. and make sure we're able to deal with any surges or peaks within that, because it's absolutely not going away. Number two is that we did a lot of great work in supporting our complex, vulnerable and shielded people, including our own workforce. And we need to make sure we are retaining the best elements of that and using that to make sure that those people we've already identified and reached out to, we continue to have an offer to those people. And this goes beyond healthcare and the wider social economic impacts as well. Number three is we need to understand the impacts of the epidemic. We know that there must be, we know because activity dropped, elective activity dropped, people stopped coming to A&E, people didn't come to GPs in the same numbers as they had before. We know there are a range of issues, therefore, which are stacking up, which we need to address, and we need to identify those and be proactive in how we open up services and prioritise services to deliver against that backlog of care. Number four is we need to kind of lock in some of those beneficial transformations that have taken place. So, for example, digital, as we mentioned a couple of times, and patient assisted engagement, that is going to be really important. So we make sure we're getting the balance of digital, for instance, right. And we need to be working together to switch back on our planned care or elective care. So when you make an appointment, see a GP, we need to make sure that we're doing that in the way which is supported by the system as a whole. And number five is that we do need to achieve financial balance as a system as well. And then we have a range of deliverables we've identified, which I don't propose to go through one by one. So for each of those priority areas, there are a range of initiatives which we think are important to us and to our patients in order to allow us to move to more back to I will use the phrase, the new normal, which is what we're all having to face up to and understand and interpret. And we believe if we get that right, we will deliver these short-term outcomes, these medium-term impacts, and we will also be aligning ourselves to the Barnsley 2030 plan, which is currently in development as well. There are some considerations. So the risk of continued C19 infection is an ongoing risk in terms of potential surges and peaks. So, for example, we saw yesterday in London, the Hillingdon Hospital, that emergency admissions had to be suspended there as 70 medical staff had been in contact with coronavirus, people suffering from coronavirus, and that led to a quite rapid escalation in the way in which that particular hospital was able to deal with emergency incidents. And of course, that could happen to any of our organisations, health and care, and to our primary care practices as well. So we're putting in place plans to ensure we have a robust response to all of those. I won't go through all of these in detail because I'm conscious of time, but the governing body just takes note. And then they ask, which is building on the development session which we had on the 25th, and a conversation we had with our partners at our Integrated Care Partnership Group on the same day in the afternoon, and from some initial engagement with our Clinical Senate as well on the 30th of June. So governing body has just asked to just agree, as you did in the development session, just to approve these priorities and deliverables, noting they will be subject to change as we have to react to C19 and other factors, but noting that those priorities and deliverables today will allow us to continue to engage with system partners and lead and push forward the transformation plan required to deliver against those 5 priorities. So I will stop sharing at this point and open to questions.
Just thank you, Jeremy. Can I come in, Jamie? It's really helpful, a brief run through of the COVID-19 and the impact on the system, as well as how we kind of galvanize the collaborative working and system-wide partnership working to achieve the collective success. While we are all conscious that we need to kind of lock in some of the benefits that we kind of learned from this COVID-19 and the impact. One of the things that I think we probably need to be mindful of is that there wasn't any pressure in each individual organizations about balancing the books. There's guaranteed income through the block contract and arrangement. So once the financial pressures is off, the boundaries and the walls automatically come off. People are able to and willing to work and flex the system to try and work across. And I think if that rules of engagement, if those sort of contracts and various things kind of changes, goes back to the pre-COVID times, we might actually have some challenges to try and lock in those sort of benefits. That's something we need to be mindful of, how we kind of not lose the benefits, what we learned. But at the same time, if the rules changes back to that, how do we actually manage it? That's something we need to be conscious of.
Yeah, I fully agree with that, Sudhakar. Just something I just want to add as well is that we've been working in a command and control set of arrangements, sort of kind of gold, silver, bronze. Really conscious that we've had a sort of a limited number of people and organisations involved in that to this point. And I think we do now need to rethink how those structures work and who we are engaging within that to make sure we get a wider representation from across our health and care system. So care representation, for instance, how do we do that? CVS representation, how do we do that? What's the best way forward there? So we're just thinking our way through that at this point, and we'll be reaching out to those other organisations in the near future.
Okay, any other thoughts? No? Can you hear me?
Again? We could hear you. I think you're on mute, Nick.
Yeah, can you hear me now?
Yes, Chair. Yes.
Okay. Okay. So governing bodies asked formally to approve these priorities and deliverables in public. Are we happy to do that?
Yeah.
Yes.
Yeah. Okay. So thank you for that, Jeremy. And probably one of the reflections is the size of the task that we're currently engaged with and for the future. But we keep going. Okay, can we then move on to item 12, cancer programme update? Siobhan's joined us. Hussein?
Yes, thank you, Chair. Good morning, everyone. Assurance paper to the governing body and the people of Barnsley, cancer update. Hope that everyone had a chance to read the paper. I'm just going to give a briefing of the paper. During the COVID surge, as we know, there was a drop in the referrals by 80% especially in the month of April. But now we are back up to 80%, but not fully 100% yet. What we did is we used several methods to encourage people of Barnsley to come to the GPs and the importance why they should go even if they had worries about the COVID. This had improved the referral rates. We are, like I said, up to 80%. And we used various methods like article in the Chronicle and then also on the social media like Facebook, etc. We used people's feedback as well to make sure the messages that we were the right ones, and so that people needed to hear why not going to A&E or why not going to GPs would make the problem worse, and gave them the assurance and told them that it's safe to to go to these places as if they needed it. People who had already been referred were also had several phone calls and virtual calls from the hospital to explain the situation to the patients, to allay their fears, and also moved people on to alternative treatment if they wish not to go to the hospitals, and also made sure that people who need to be seen first were seen. And lots of people did continue with their chemo and did have their relevant tests and treatments, etc. However, there was the biggest hit was the endoscopy. This was due to the risk of spreading the COVID. Now we are continuing to focus on those patients or people who are waiting the longest for treatment dates. We're doing this by asking patients to go to other institutions like Claremont Independent Hospitals, but some patients have found this difficult, the travel and so on. But the choice is out there for them. Also, we are working with the NHS England around extra resources for undertaking tests in the community venues. Also making sure those who are waiting for the tests or starting treatments are clinically triaged, so least harm comes to them. Monitoring if people needed to be diagnosed are at a higher stage. We are introducing more tests to help people who need to be seen first, like example the FIT test for suspected bowel problems, bowel cancer. We have increased the clinic times as well to 12 hours from 8 a.m. to 8 p.m. Also, the hospice is back up for inpatient beds, and these are being used. But however, the daycare is not still back up yet. There have been issues with lower and upper GI and urology backlog, which diagnostic activity has increased. Number of people waiting also has increased. Means for some people the waiting time is going to be a bit longer. People who are not still coming forward, so we still continue to show videos by GPs and nurses, etc., to say that these places are open for business as usual, and what we are doing to make it safe for these people to attend clinics and surgeries, etc. The issues mainly is the social distancing, which has reduced the spaces in the hospital, like in the endoscopy theatre. So there's quite a considerable backlog, which needs to 120% of capacity to reduce this. But at the moment, we are only running at about 75% the capacity. Screening, started cervical screening as early as we could, and starting to open up out of our service again. We never stopped seeing people who had tests and needed further treatment. Breast continued, but on a much smaller scale. We are hoping to get this back up to normal and clear the 3-month backlog, but not likely until in August. Excuse me. So in summary, we are working with South Yorkshire and Bassett Law to bring some resources to Barnsley to minimize any harm to patients who are waiting for treatments, making sure people know what we are doing, so people are involved, are engaged, and then information is given to them, emphasizing to people not coming forward and why they should come forward, the importance of coming forward and how that that can help them. Yes, that's it.
Okay. Any questions for Hussein or Siobhan? Or Siobhan, anything you would like to say?
No, I just think just to pick up that actually the screen in the backlog will take some time to be able to reduce, and we hope to have it back online by August, but just to put that point really.
Thank you. One of the things in the governing body ask is to make additional recommendations or comments and to consider future priorities. Is there anything in that do people have thoughts around that? Is there anything we're missing in terms of priorities within cancer? just a sense check. The paper's quite comprehensive, but it's an opportunity for us just to think if there's anything extra that we'd like to see or something that we'd like to see prioritised more. No? Okay. So we've noted the paper, we've reviewed the priorities, we've agreed to support the implementation of the actions and deliverables. And
Nick,
yeah.
Sorry, Nick, I think Chris Millington had his hand up there a moment ago.
Right, Chris.
It's really is a question around, say, me or my family, and I know that we've all been working very hard, but it really is if me, Chris Millington, is in that position, or if one of my neighbours is in the position of a cancer diagnosis, and I have two pals at the moment in that situation. Just how do I actually get the information that's relevant for me? Is there a single point of access? I notice that we've used the Chronicle, and whilst the readership of the Chronicle isn't absolutely fantastic nowadays in Barnsley, it always worries me that we've got these things in place, but the people who really need to get to them, can they get to them? Big question.
Well, patients, as you know, Chris, if they can always ring the service, the GP, and speak to the GP, or and then the patients, if they have any worries, they are brought into surgery for face-to-face consultations, and then any concerns they have, they're addressed, and appropriate referrals are made to the to the supporting services. That still happens. So if any concerns, anything, just to speak to the to the surgery, to the GP.
Okay, thank you.
Were you thinking about comms, Chris?
I am really, yeah. There's all sorts of things out there that we can do, but it really is a question of the ability of people to actually do that. We are fortunate in that we've got internet access, we've got friends and family around. There are an awful lot of people out there who are living alone, who are isolated. Have we recognised these people? Are they actually on our radar? I want to say yes, they are, but when I get asked these sort of questions by members of the public via governors and via again patient council, I do struggle sometimes to give them reassurance that we really are on top of everything. I'm sure we are. It's a simple question: is how are we doing enough in terms of the simple things, not the big things, the simple things in terms of communication through free papers, through the Barnsley Chronicle, through local radio, say. I mean, local radio can be quite fantastic. So that was my only concern, really.
So at this point, I'm going to invite Kirsty to respond, and then I've got Dr. Addy Cunley and Mike Sims. So Kirsty, responding to Chris?
Yeah, I think I agree with everything that Chris has said. It's really tough, particularly now, because if you think things like the cancer champions that we had, that they were there to fill this gap. So I think there's two things: A, do people know about it? And B, do people have the confidence to come forward to their GPs? And they're two separate things, but they're quite linked. And I think the comms thing won't solve the second thing. So it's got to be about a combination of all of those. But I think you're absolutely right to raise it, Chris, because again, coming back to the patient story, people like Michael didn't want to make appointments with his GP, very anxious to use the phone, felt very overwhelmed. and we know that isn't unusual. So I think there's two bits. I think there's being clear about the groups that we want to target, and how do we do that, and that was different than it will be during COVID, because there will still be some of that fear around coming back into health services. There will be some still fear about what will happen afterwards. So I think, it's something that we will obviously be looking at, but I think it's definitely a good point to raise there.
And what assurance could we give the public that we're going to be looking at it? What's the product going to be? How are we going to? So perhaps we could do some feedback as to what we've put in place for the most isolated because of COVID and the most vulnerable.
Yeah, and I think I mean those plans are still in development, but I think it's what we picked up on earlier. It's the partnership work. So it's working with. So we had something like, I think it's 67,000 either households or individuals in Barnsley that were shielding, and we've got, we know those people. We can contact them directly, but we've never done that before, and that's sort of going right into their houses rather than perhaps them opportunistically even seeing it in a newspaper or hearing it on the radio. So I think we've just got to be a lot more targeted and a lot more slicker, and I think the thing we probably need to consider is that that's we can't do that for free, so that there will need to be some budget that goes with that, but I clearly think that this is going to be something that will take us right into next year.
And so I think the thing that governing body are hearing is some concern about the most isolated, the most vulnerable. So it might be an ask of perhaps Chris and yourself to get together and just work through, and perhaps with Jeremy, how we would do this through the partnership. Yeah, so we put some bit more flesh on that. What do you think, Chris?
We don't have to work harder. We just got to work smarter. We have, seriously. You don't necessarily have to work twice as hard. You just got to identify the real key issues and work smarter.
Yeah, and I think so. Dr. Kadashi said, didn't he? We did some very targeted activity, and actually that started to sort of open up the doors a little bit more. It gave people confidence, so they did react to it. So we know some of the things that will have an impact. So yeah, happy to do that.
So a few people, just quickly, Jeremy, because you'll respond on the partnership side.
Yes, absolutely. So we have a community resilience cell as we're calling these work streams. It's building on the work that the local authority and we in health developed to identify that vulnerable populations, and not just the shielded population, those with the most complex illnesses or underlying health conditions, but more widely as well. So we do have a range of information available to us now, which is much broader than we've ever had to this point in time before. And we've been allowed to do that because information governance rules have been relaxed for a duration until the end of September. After that point, we won't have quite so much freedom in terms of how we use that information, but we need to understand how we can retain as much of that information sharing as possible. It's a really key task for us. And I think Nick, it would be really good to bring some of that to you and your colleagues, so you can see what information is there that has been used by the contact centre and others. So we can start to build on that and think about how we use it as commissioners and how you use it within primary care. Yep, that would be good. Thank you, Jeremy. Debo, you've been patiently waiting.
Thank you very much, Nick. Thanks, Chris, for what you have mentioned, and I fully support what he has mentioned, how we can engage the public as a whole and giving appropriate information. I just want to share just two prior things that we've done in our surgery, and just for my colleagues. I don't know whether all the practices have got texting services in their surgery, because that's one of the ways by which we have been able to contact patients and give them information about things and when they can contact the surgery. And secondly, we have regular calls to some of these vulnerable and shielding patients, which is done by our receptionist, and it's done almost, I think, every weekly or fortnightly. And we have been able to find out from some of them some symptoms which they wouldn't have come up with, but because somebody is contacting them regularly, they were able to just open up to say that these are my symptoms. We brought them in, we saw them in the surgery, put them at ease or investigate them appropriately.
Thank you. Mike? Mike?
I mean, I think there's been a lot, yeah, sorry, I'm just unmuting. A lot of talk about the hidden harm of COVID, and I think cancer is one of them, because a lot of our cancer services could barely cope before the lockdown. There's basically been a pause of services for 3 to 4 months. And there's now a significant backlog of people who, at every level, those who haven't presented yet that in primary care, those who are waiting to be seen in secondary care, and those waiting for investigation. And I think, I mean, the talk is that services will have to work at 120%. And even with that, it will take over a year to get through that backlog. At the moment, with all the smart working they can do, they can only get up to 80% because of the problems with working alongside COVID and with PPE and everything. So I think there has to be a lot of smart thinking about how we sort out the cancer backlog, because it's we have plans and everything, but we're certainly a long way from sorting it out at the moment.
Okay, Jeremy?
Yeah, I just wanted to pick up on that, just re-emphasise it really. I think did we see in the national press the other day figures that came out showing that there may be an additional 35,000 deaths due to backlog in cancer waiting lists over the next year or so. I do think actually as a key priority in terms of a service area that we as a CCG Commissioner working with the Cancer Alliance need to put a lot of energy into this actually, both across our integrated care system and within Barnsley itself to maximise capacity and throughput and screening as well. I think there are some real challenges in there, and I think we probably need to dedicate some real resource into this one.
Okay, so thank you for that. I'd like to say thank you to Hussein and Mike and Siobhan for doing lots of really good work on this and providing assurance to the governing body in these difficult times and in this particularly difficult area. So thank you for that. If we can then move on and take item 13, which is the quality highlights report. Jane is here to note.
Okay, thanks, Chair. So our Quality and Patient Safety Committee met last Thursday, and as one would expect, it was a very busy agenda, especially during this time. The committee would like to highlight 5 quality areas to governing body, which can be found on page 5 of the Quality Highlights report. The first one is a change to the committee's membership, which will now include the CCG Specialist Clinical Portfolio Manager, and it was agreed on the basis of this individual and this post providing additional clinical input because of the expertise in areas such as liberty protection safeguards, court of protection, consent, care homes and so on. So the committee agreed the change and that the committee's terms of reference should be updated accordingly. The second is with regards to safeguarding. The committee invited the 2 designated nurses for safeguarding for adults and children to the committee last Thursday, and it was very much a deep dive with regards to what activity for both children and adults took place during COVID. The committee were assured with regards to what has happened, obviously the support we've been giving across Barnsley and across the integrated care system with regards to safeguarding. The committee were also advised that the safeguarding team and myself are pulling together an annual safeguarding report to QPSC, which will obviously come to governing body following that meeting. The third is the outcome of the D1 audit report, or the discharge information that goes from the hospital to primary care. And this was presented by our head of medicines optimisation. So the committee acknowledged that the results demonstrated that some areas of practice had improved. However, there was still considerable room for improvements to be made. So the committee agreed that the committee would maintain focus on this area going forward, given the potential risks to patient safety. The fourth is with regards to 3 policy updates that was presented by our lead commissioning and transformation manager. So the first was the access to the infertility pathway, where the committee recommended that patients exceeding the age limit due to long waits should have their case reconsidered by the IFR panel. The second policy was the management of patients with musculoskeletal and rheumatic conditions, and the committee agreed no change to the pathways for management in that area. And the final one was the Get Fit First policy, with the committee noting that the policy continues to apply, but GPs being asked to use their clinical judgment and make referrals in parallel with starting the 6-month period of health improvement. And the committee agreed to review the position in 3 months' time. The final area that the committee wanted to highlight to governing body was with regards to the implementation of liberty protection safeguards. As you know, this will be to replace the deprivation of liberty safeguards, otherwise known as DOLS. So this has been postponed to middle of 2021. Which the change had been due to take place from the 1st of October 2020. So the committee noted this, that it had been postponed, but acknowledged that the CCG needs to ensure that it is ready for this change in good time, because there will be significant organisational and system impact in terms of corporate risk and so on. So it was noted that work will begin to start with the information that will come via the routes with regards to draft implementation of liberty protection safeguards and so on. So that's it, Chair, with regards to the 5 areas the committee wanted us to share with governing body, and myself and colleagues that in the governing body that are part of the Quality and Patient Safety Committee, happy to answer any questions.
Any questions for Jane? No? I've just got one question for Richard, and it's probably a bit of a governance point. When a committee changes its terms of reference, can it do that, or does it have to recommend them to governing body to approve, or is it enough that it comes in through their annual committee review that we have?
No, I think we would ask governing body just to give its approval to that change, Nick.
Yeah, so we can do that now, can't we?
Yeah.
Yeah, that's fine. Anything else, or can we move on?
Just one thing, Chair, just to add to Jane's presentation on the quality highlights report, I would reinforce the point that was already mentioned, is that we need to keep the focus on the D1 discharge summary, because some of the key elements where if a medication is being changed or stopped and the reasons for stopping or changing them, and then putting the reasons and highlighting them to the GP, those sections are the ones that needs more improvement from the audit results. And also the pharmacist checking the medications before the patient getting discharged. That's an area that needs to be improved as well. So I think, yeah, I think if there's going to be somebody whoever is replacing my position, they would need to pick this up and then have continued conversations working alongside with Chris Lawson, trying to show those improvements.
You're muted, Nick.
I am muted now.
Yes.
Yes. Oh, good. I was going to say, so having received the highlights report and approved the changes in terms of reference, if there are no further questions, we'll move on. Thank you, Jane. Can we move on to item 14, risk and governance exception report? Richard, please.
Yeah, thank you, Nick. So I've just tried to set out in the paper a bit of an update on a range of governance issues, just so that governing body and the public are aware of where we've been through the COVID pandemic on a number of things, and how we're now beginning to gradually move back into a more normal way of working. So just very briefly, as far as the assurance framework is concerned, that was something that was kind of suspended when COVID kicked off, because we were in the process at that point of thinking about what our priorities might be for the 2021 year. Obviously, that process was put on hold while our focus was on COVID. We're now, I think, in a better position to know what our priorities are going forward. Jeremy articulated some of that earlier on, and we're expecting planning guidance out, I think, in the next couple of weeks from NHS England. So once we get that, I think we should be in a position to rebuild our assurance framework and begin to report that through governing body in the usual way. The corporate risk register, by contrast, we have continued to review and update that through the COVID period. And you will see that that's been included in your papers for governing bodies assurance, and also if there are any comments or thoughts on the risks contained therein. As far as the committees of the governing body are concerned, again, as we went into the peak of COVID, the work of our normal committees was largely suspended, as the focus was on the sort of response to COVID that was handled through the Gold and Silver Command sort of arrangements that Jamie was able to tell us about earlier on. We are now, as we move, as I say, back into some semblance of business as usual, all of the committees of the governing body have now been sort of brought back online and are meeting, albeit through the virtual arrangements similar to this one. Declarations of interest, again, this is just for assurance. We've continued to collect and to publish declarations of interest throughout COVID, particularly if there's been any new starters and so on. So that's really just assurance to say that's still happening, and they're available as always on the website should anybody interested in seeing those. Freedom of information is a statutory responsibility that we have. That was one that was not stood down when COVID took place. The public has been able to make requests under the FOI legislation throughout, although the Information Commissioner's Office did signal that there would be no sort of action taken against organisations that found it difficult to meet the statutory deadlines around responding to FOI. I think it's a small but significant success story for us that actually, throughout COVID, we have still continued to receive FOIs, and in the vast majority of cases, we have been able to respond within the statutory deadlines to those. Just 2 or 3 instances where individuals were so focused on COVID that we might have missed by a couple of days, but I think that's actually quite a good effort. Paige Dawson has done lots of work on that in my team, but people across the organisation, have really stepped up and helped us to keep on top of that. So I would just note that and thank those who've been involved in it. Corporate sort of CCG policies and so on. Again, just for assurance, there was a period in the height of COVID where some policies that were due for review may not have been picked up in quite the timely way we would want to. We're now back on top of that. We are reviewing policies in accordance with the normal timeframes, and they will start coming through the relevant committees as necessary. The annual report and accounts, obviously governing body members will recall that we had a meeting in June where we signed off and approved the annual report and accounts at the conclusion of the audit that was undertaken by KPMG. Again, just to close that loop off, subsequent to that meeting, we received the opinion from KPMG, and those have now been published on the CCG's website. So that, in a sense, puts the 1920 annual reporting process to bed. And then finally, as far as sort of governing body work plan is concerned, again, just to note for the public, really, we are now, this is the first of what will become the routine sort of governing body meetings from now on. So we're back into a 2-monthly cycle of governing body as we were before COVID. We're going to continue to engage the public. Obviously, we can't have members of the public actually present at meetings, but we're going to do a number of things to keep the public engaged. That's put the papers on the website, put recordings of the meeting on the website. We're giving members of the public the opportunity to ask questions in writing in advance. So, you know, we think we're doing what we can in that regard. We have now pulled together a work plan, and that again was in the pack, so that we've got a schedule of work for the year. And as the assurance framework comes back on stream, we'll be able to schedule in regular updates on the key priorities in the assurance framework as well. So that was really all I wanted to say. You know, any comments or questions, I would be glad to try and answer. Nigel, did you have a question?
Yeah, well, question, but comment more accurately. In terms of the risk register, and we've put the same sentence against all the risk continues to be monitored, etc., etc. And I think that was reasonable at the time it was done. I suppose my comment is that if COVID-19 is going to be around for the next 18 months to 2 years, when does that sentence become obsolete and we actually do something?
It's a fair point, more than fair point, Nigel. I agree with you, and we talked about it at Quality and Patient Safety Committee the other day. That in actual fact, we're probably past the point now where that's a reasonable response to some of these things. Yeah. Either they've ceased to be risks for us, in which case they need to be taken off the risk register. Saved by the bell there, eh? Or we need to be properly updating those risks. So I did give the assurance at QPSC that we would get a proper update to some of those and share that around the committee. And I'm sure a similar approach would work for the other committees as well.
Yeah, I think a good point. I think the other thing that I picked up there, Richard, was we're working on some sort of risk articulation around COVID itself,
yeah,
and its impacts on the others, and maybe for our, I don't know if we have some sort of meeting in August, it might be an idea to set that as a timescale just to start to work through that, because I think it'll be an interesting one to try and articulate and also to try and score.
Yeah.
But with regard to Nigel's comments, the COVID impact on the individual risks will be variable. So we've got a bit of a job to do there, haven't we, going forward?
Yeah, agreed.
Yeah. Okay, if there are no other questions or comments, I'd like to thank Richard. And Richard, extend the governing body's thanks to your FOI team and Paige and other members, please. Thank you for that. We'll move on to item 15. Roxana, please, integrated performance report. Roxana and Jamie.
Yeah, thank you, Chair. I'll cover the finance section first, and it's in a few component parts this month. So yep. there's the first part is around the new financial regime that we are in as a result of COVID-19, which sets out the financial allocation that we received, which is actually different to the notified allocation that we received as a governing body from January 20. So actually the CCG, as part of the NHS England, as part of the COVID response, issued CCGs with allocations for the period April to July. The report sets out that allocation for Barnsley was 150 million. If we extrapolated that position up for the full year, that would mean that Barnsley were £11 million short of our notified allocation. So clearly some significant issues in relation to that, whereby the CCG would be able to achieve financial balance. NHS England also mandated block contracts to NHS providers, which has been previously reported to the governing body, which took 1920 values of activity that were being paid over to trusts with 2.8% of growth and no efficiency. So therefore, that clearly puts the CCG in an, again, difficult position, given the fact that our significantly high 1920 activity numbers, which we had a £12 million quip essentially against our main provider, Barnsley Hospital, is not currently being delivered again, from a financial perspective. So though it's just very important that we note those two key points in terms of the shortfall in the allocation against the background of having a block arrangement that has been mandated. We've done a forecast, an initial forecast as a team to month 4, which shows that we are likely to have a deficit position of around 6.6 million. That includes COVID-19 costs of in the region of about 2.3 million. That position is constantly evolving as we kind of responding to COVID, and any further decisions get approved through our SMT Gold Command arrangements that we have in place. The report sets out the year-to-date month 2 position, which we did expect to be reimbursed through non-recurrent allocations. So that showed a 3.4 million deficit position, with 1.2 million of that relating to COVID. We've had the COVID allocation, we've received that now, but what we've not received is the 2.2 million balance. So NHS England have said that they would like to do some further assurance across all CCGs within that that this applies to, and that they expect the position to be adjusted in month 3. So we've done quite a lot of work this month to articulate to NHS England the rationale and the reasons behind that position for month 3, in the hope that we will then receive the non-recurrent allocation, because clearly at the start of COVID, the response from NHS England was that the NHS will receive what it needs, and we're not quite in that position yet in terms of being able to show a balanced budget position. So as things currently stand, we are reporting a deficit position, but my expectation would be that that is removed once we move into month 3, and certainly as we get into month 4. And I'll just pause there before I kind of move on to the next section if anybody's got any questions. Chris?
Yes.
Yeah, very briefly, Roxana, for the members of the public who may be watching this, if you could explain QUIP.
Yeah, so QUIP is the CCG's effectively, it's the efficiency programme that we would look at. So it's looking at quality improvements, productivity, and making sure we can release efficiency across our contracts, if you like, to ensure that the CCG can achieve financial balance.
Thank you.
Any other questions for Roxana?
Okay, so I'll move on to the next section of the report then, which kind of just sets out for governing body the COVID-19 costs for May. As I've just previously set out, those have now been reimbursed with April costs as well, so we have received full reimbursement for those COVID costs. Detailed further down in the report are also other approvals that have been made through the SMT Gold Command that have not yet been claimed, but will be included in future reimbursements to NHS England. So they're just to note there, and they'll appear in the next month report that the governing body receives. That's my finance update.
Okay. And we're asked to note those 2 bits as a governing body.
Yes.
Yeah. Okay. So thank you, Roxana. Are there any questions for Roxana before we ask Jamie just to go through the last bit of this? No? Jamie? Thank you, Roxana. Jamie?
No problem. Thank you. I think I can do this relatively quickly. We've had a discussion at Finance and Performance Committee. I think we're presenting this information in a slightly different context to how we would usually. So we're presenting this really to note the impact that we've seen on performance, as opposed to, as we usually do, to assess delivery against the Constitution standards and key measures, and then to identify mitigations, because I think we know that over the last few months, things have been happening that just have had an impact on ability to deliver. So what you've got included is the two appendices, and apologies, they might be the wrong way around. So I think 15.3 is the 1920 end position, and 15.2 is then the latest position that we had available for this year. And all I wanted really was just to reflect on, so where we've talked earlier around people needing to wait longer because we can't access services and other things, people coming forward, the areas that we're seeing showing as red and where we've seen a drop off in performance are around things like the 18-week referral to treatment time, because we can't bring people in for elective surgery, so there's been quite a drop off. So usually we're above the 92% standard RTT for Barnsley patients. During this period, 77% have been seen in 18 weeks, so reflecting again some of the backlog that might be building there. We're seeing 52-week waiters, which we very, very rarely see. Diagnostic waits, usually less than 1% wait more than 6 weeks, 71% waiting 6 weeks as it currently stands. So I think it's just worth reflecting that. On the counter side to that, we've seen reduced activity levels, which we've referenced through, which appear on some of the indicators in the table that you've got to be showing a positive green position. And I think in some that might be right. So A&E, for example, the reduced numbers that have come through, we have therefore seen, because of the modelling, an improvement. So nearly at 95%, not quite, but close to being there. But the one that I think is worth flagging, and we've just had a discussion about around cancer, is that some of the measures there around 2-week wait, 31 days from referral to treatment, etc., probably provide a false assurance if you take it that way, because the reason that people have been able to be seen is because there's been so fewer numbers coming through during that sort of first couple of months. So when we talked under the cancer assurance report about that big dip in 2-week referrals, the performance that you're seeing here on the 31-day part of that is as a result of there only being very few coming through. So I think it's just to reflect that point back, and it does sort of mask really what Dr. Kadarsha said around some of the longer waits. So we are seeing increases, and it does show there around people waiting more than 62 days. But even, and this is a Barnsley issue, an SYB issue and a national issue, people who are waiting longer than 104 days. And I think that's already been flagged earlier as an issue that is now a priority for us and for the Cancer Alliance. So that's all I wanted to say on that. So we're just to reflect how this has impacted on performance.
Any questions for Jamie? No? Okay, thanks Jamie, thanks Roxana. So we now move on to a series of committee reports and minutes. So the first one is the unadopted minutes of the audit committee of the 18th of June. Nigel, is there anything you wish to pick out particularly?
No, this was a committee meeting that reviewed the annual report and accounts and various reports from auditors and recommended to the governing body the adoption of the accounts. So thank you.
So we've seen that through public. Thank you. So next one is finance and performance that we had on 18th of June. Those minutes are adopted. Happy to pick up any questions. And no, so then we move on to 16.3 assurance report from Primary Care Commissioning Committee of the 28th of May. Chris, is there anything there you want to draw to our attention particularly?
Thank you, Chair. Yeah, there is one particular point, but as you can see, the report is here for assurance, and it talks about the Cocotti practice being inspected by the CQC on the 10th of December. Burley Medical Centre was inspected on the 4th of March 2020, and it also covers Longwood and Huddersfield Road surgeries. I'll come back to that particular bit. Item 2, here we go with jargon again, QOF, which stands for, means quality outcome framework payments. My clinical colleagues obviously will understand what that is, what's behind all of that. But we are going to be continuing these sorts of meetings. So I'll say again, in relation to the glossary, which we need to put together, there needs to be something that will link and be able to, for the members of the public to be able to understand that very clearly.
Yeah, and just thinking about that, Chris, just thinking about how we might do that, rather than have Richard go through and make an extensive glossary, perhaps the better way would be for each committee, as they prepare their reports, to do that mini glossary, and then Richard could just pull it all together if it was necessary. But there would be greater understanding from each committee and how to articulate it, and then perhaps Kirsty could have a look to make sure it's user friendly. So I think that might be better than one massive glossary. Yeah.
Okay.
But certainly your point's a good one, and we take it on board. Carry on.
Okay. Well, the good news is the good news today, and it is good news in that across Barnsley we have 33 GP practices, which the general public may not know of the actual numbers, but of those 33 practices, 30 of those practices are rated good by the Care Quality Commission. 2 are rated outstanding, and we have just one concern at this moment in time, but we have a very robust dot-to-dot action plan in place to assure everyone that's concerned within that particular practice. And I don't particularly want to put the name in the public domain at this moment in time, but just to reassure that overall in Barnsley, 33 practices, 30 are good, 2 are outstanding, which is good news for the people of Barnsley.
Yeah.
Any questions?
No, thank you, Chris.
Thank you.
So minutes of quality and patient safety, 20th of February. I think that's been superseded by highlight reports. And that those minutes have been adopted to there for information. Then we've got report circulated in advance, and there was a ICS Chief Exec report from Andrew Cash from March 2020. It's been circulated, which brings us on to the end of the meeting. So I'd like to thank all governing body members and thank members of the Barnsley public who may be viewing this recording subsequently. I'd like to thank Kay. One special thank you today would be to our medical director, Sudhakar, Dr. Krishnaswamy, who's leaving us. So this will be his last governing body meeting in public. Sudhakar and I started as executives of various commissioning organisations in August 2009. So it's been a long journey. And I'd just like to thank him on behalf of the governing body and the people of Barnsley for all his contribution to putting the people of Barnsley and outcomes for Barnsley people first, and the support that he's given to colleagues, and to wish him well in his future and to carry good memories with him. Thank you, Sudhakar.
Thank you. Could I come in, Chair?
Yeah.
Okay. First of all, it's been a huge honor and a privilege to serve the Barnsley public through this medical director as well as in the governing body role. I thoroughly enjoyed working with the CCG colleagues, and I made some fantastic professional relationship with a lot of good kind of working relationship with a lot of good people and colleagues, both in primary care, community service, CCG and acute trust, so across the boundaries. And I'm fortunate enough to lead or get involved in a lot of fantastic pieces of work over the period of last 7.5, nearly 8 years come August. So I would sadly miss this good organization. So I'll carry a lot of positive memories with me. Once again, thank you to each and every member of the CCG and the rest of the partners across the system for their help, support and cooperation in putting the people of Barnsley first. Thank you.
Thank you, and our best wishes go with you. At that point, I think it's probably reasonable to say we now move to the private agenda, and I think it's probably a good idea if at this point we end the public and stop. Jamie, sorry, I was going to say we stop recording. Jamie.
It's all right. I would just to comment sort of on the back of what Sir has just said and what you just said, I guess, just how different this is. So usually, if you were making this decision and leaving today, we'd have a bit of a get together and a celebration, allow everybody to say goodbye properly. We won't be able to do that. I was just going to say, you know where we are. When we do get back into Ilder House, feel free to bring them buns.
Certainly. Yeah. That's something I will miss, actually. I wanted to give a kind of a face-to-face goodbye, but I can't at the moment, and certainly I'll come back once the guidelines are relaxed. Yeah, thank you.
Yeah, that's good. Thank you for that, Jamie. So at that point, we'll end the public meeting. Kirsty and Richard, if we could stop recording. Thank you.